Major funding for these programs is made possible by grants from Capital One Bank, New York Community Bank, Eastern Consolidated, M&T Bank, Customers Bank, Meridian Capital Group, Terra CRG, the Witkoff Group, Perfect Building Maintenance, Chase Commercial Term Lending, Chase Commercial Mortgage Lending, Genova Burns. Additional support is made possible by AKA Hotels, Corman Communities, AmTrust Title, Ariel Property Advisors, AVR Realty Company, Bank of America Merrill Lynch, Bank Leumi USA, Briarwood Organization, CBRE, Citizens Bank, Connect One Bank, Colliers International NYC, Collins Building Services, CPEX Real Estate Services, Dime Savings Bank of Williamsburg, Douglaston Development, Levine Builders, Fisher Brothers, Flushing Bank, Friedman LLP, Hendler Real Estate Organization, Hersha Hospitality, HAP, Investment Developers, Hodges Ward Elliott, Inc., Investors Bank, iFunding, James D. Kuhn Real Estate Center at Syracuse University, Kilroy Architectural Windows, Madison Realty Capital, Matone Group, Mercantile Commerce Bank, New Banks, Newmark Grubb Knight Frank, Optimum Window Manufacturing Corp., People's United Bank, Paulsonelli, Rosewood Realty Services, SJP Properties, Sterling National Bank, Stonehenge Partners, TD Bank, The Continuum Company, the Knackle Group at Cushman and Wakefield, the Meringoff Family Foundation, the Moynihan Group, and these friends.
Healthcare 2016. What's going on? Part 1, we discuss certain aspects of what's going on. And on Part 2, we're going to talk about some other segments like sponsorships, doctors working for hospitals, doctors going to house calls, and what's happening with insurance. My guests today include Tony Ferreri, the Executive Vice President of Northwell Health, Gary Colcutt, Senior Vice President in charge of Network Affiliation and Integration at the NYU Langone Medical Center, and last but never least, Dr. Andy Racine, who is the Chief Medical Officer, Senior Vice President at the Montefiore Medical Center, Montefiore Health. So, besides every corner of this in the city of New York having urgent care centers today, we're seeing more ambulatory surgery. We're seeing hospitals changing their way. How many days is the average patient going to be in a hospital today?
Those are all good questions, and I don't know that we know the answer at the end of the day, but I think some of the trends that you've mentioned really are from the standpoint of not just how you can do things with less expense, but how you can do things more safely. We all take care of patients in hospitals, and we know that hospitals are not the safest place for people to be. And if you can perform a surgical procedure in an ambulatory surgical center where all of the surgical aspects of it are safe and the quality is great, you're much better off not having those patients in the hospital if you can avoid it. There are issues about infection, there are issues about other kinds of complications that you can get away from if you can do it in that kind of a setting.
And I would agree with Andy that it is about the patient, and safety is primary, but it's also about patient convenience and access. They'd rather be in an ambulatory surgery center where they can go in, have the surgery, and leave, and not have to navigate a hospital system, which sometimes is difficult. And the other piece is it's less expensive than being in a hospital, but the main piece of it is the technology now allows people to be cared for on an ambulatory basis instead of being in the hospital. And to do it safely, and perhaps more safely, as Andy says, than to be in a hospital.
Now, you've built a number of ambulatory centers, okay? You've always had them in Staten Island, but a number of your affiliations or new ownership in Long Island have these ambulatory centers?
Well, the concept of ambulatory surgery is not new. Where I was the president and CEO of Staten Island University Hospital, they built out a separate same-day surgery suite with 7 ORs some 18 years ago. And as Gary indicated, with the advances in technology, the advances in medicine, you've seen more of a proliferation of these AmSurg centers, and not so much, and you still see them being built on hospital campuses, but you're seeing a lot more of them being built outside the hospital. And as indicated, it's for the convenience of the patient. We're able to take care of patients better. There's less infection, there's better recovery, there's better outcome in terms, but it of course has to be appropriate to what the type of procedure is. And we're seeing with each day that passes, each year that passes, we're able to do more and more invasive procedures in an AmSurg setting. And it does work well, it does.
Question, when the two of you went to medical school, there were very few advertisements in all the magazines and all the newspapers for services. How important are the advertisements, and how important are these ratings in U.S. News and World Report and the Castle and Connolly Report of the Best Doctors? How important is that on what you do today in healthcare? I mean, you just went through a new TV campaign.
Right. I think that, it has marginal importance. It has to do with being able to let folks know the kinds of activities that you're involved with and what you can provide for people. I think that right now, all of our institutions are, in a sense, buffeted by lots of external folks who are putting out ranks and things like this, and they're all based on different methodologies, some of which are more robust than others. I think at the end of the day, the institutions have to decide what's their core mission, what are they trying to accomplish. If they pay attention to that and focus on that, that's really going to be, at the end of the day, what's going to get them to where they want to be. That's my feeling about it.
The U.S. News and World Report actually was released today. NYU is number 10 on that honor roll list. And we may have some issues with the methodology, but I think it has outsized importance to a whole spectrum of customers, people who who are interested in NYU, from donors to recruits to medical residents to medical students and to patients, because it signifies excellence in some way. Now, again, we may argue with some of the methodology and the process, but I think it is quite important as advertising and saying who you are and what you do. As Andy
in the same way, and I'm going to follow up on two things. You have Northwell signs in Madison Square Garden. On the bench you see Northwell. On the scoreboard you see Northwell. You have Dr. Radio on Sirius Radio. How do you see that with regard to patients, doctors? There's different emotion, okay? Certain doctors like to be on Dr. Radio. Certain doctors say, it's inconvenience for me. Certain doctors say, it's nice that you're advertising, but perhaps that money should be paid to me, because we're talking that many of these doctors, which we'll get to in a minute, are really now employed by the healthcare system. Thoughts?
So, again, I think it's part of a whole of projecting who you are and what one does and what one's strategy is. Dr. Radio has been very successful for us, and many physicians enjoy that, and I think it provides a service for patients, but it also, like advertising, like U.S. News, talks about the NYU experience and the NYU brand. And I think that is, our reputational status has been one of the trajectory of improvement of that has been a major factor in the growth and the ascent of our medical system.
Right, and it's branding as well for Northwell as it is for all of the hospitals. We all cooperate in one way or another, and there have been things that have been done. We have a relationship with Montefiore. After Superstorm Sandy, Lenox Hill opened its doors to NYU's physicians and to their patients and to even their nurses to cover there. So we have a spirit of cooperation and a brotherhood, if you will, sisterhood. But at the same time, we're also competitors.
Right.
and getting the word out. And there's just so much volume that's available. There's so many needs that are out there that we collectively believe that we can meet all of those needs. But there certainly is a degree of competition that using the opportunity to get your brand out there, as Gary indicated, is very important.
We talk about competition. Competition for, as I would say, I'll put it, it's like the baseball, the leading, the RBI hitter, okay? They're a competition for certain specialists. Now, you go out and you've hired a couple of people from around the country.
Yes.
So, okay, you have a great, bench, as we would say. All the teams have different benches. How important is it to bring that bonus baby or that leading expert, in reconstructive surgery? Or, Montefiore was one of the leaders in heart surgeries going back years ago. Where do we see that?
I think the impact that, as you refer to as a superstar in medicine, the impact of recruiting someone of that stature and the impact of losing someone of that stature is great to an organization. And I've seen situations where whole programs within the Northwell system, entire programs have been built behind or around an individual surgeon. And that surgeon leaves, and it has a tremendous impact.
Let me bring this back to, look, when you run a large medical institution, you start with what are the needs of the patients that you're serving. And most of our institutions have decided that there are specific areas of expertise that they're going to concentrate on, generally on the basis of what they can perceive to be the need of the patient population. So, for example, at Montefiore, we have centers of excellence in a variety of different areas, including cardiac care and cancer care and children's stuff and transplant. So if you're going to have a center of excellence in transplant and you want to make sure that you have the best transplant outcomes of anybody in New York State, you have to get the team assembled who can accomplish that. That's what drives how it is that you decide to go into the labor market looking for people that can do what it is you need to do. And if you do that correctly and you do that well, then you're going to get the results that you're looking for. But again, it has to do with who are the patients that you're serving, what are their needs, and how it is that you're going to orient the institution that you're building to serve those needs.
And you certainly want to build the programs that are consonant with your patient population. And you want to bring in the stars are the ones who are the best at what they do. They may not be known publicly, but they're recognized by their peers. They're recognized by referrers, and that's who we've gone after around the country.
But you know what? When you say they may not be recognized by everyone, the internet has changed the world. People, when they have a condition, they search the internet and they look for the perceived best or the perceived person who's going to be there. And I think it's the question of, how much articles, how much publications, how visual, or what the semblance is around that. And I believe that due to the support of your trustees, sometimes you bring in even better people because they're out there to say that they'll put a chair in somebody's name or they'll name the department in the situation that's over there. Let's talk about, with regard to, years ago, doctors, solo practitioner. Reading the current statistics, there are very few people who are going to go into solo practice. Where do you see your doctors are employed by you? What's the percentage of the doctors who are affiliated with Montefiore are employees of the hospital?
We started out with a very large employed cadre, and a lot of what we're talking about here, and you've asked about this before with regard to what it is that determines whether or not a physician is going to come in and be a fully employed physician or affiliated in some way. We've talked about this transition over to acceptance of risk, which is what Montefiore is all about. We are a risk-based, population-based medical center. You cannot really do that as a private practitioner today out in the community taking fee-for-service medicine. You cannot do it. If you are going to accept risk, as Dr. Calcutt had mentioned in a previous broadcast here, you know that only a very small percentage of people are going to be responsible for a very large amount of your expense. And if you're all by yourself in a single practice, you can't afford to even have one or two of those kinds of patients if you're in a capitated environment. So what we offer is we say to somebody who wants to work in that kind of environment, who wants to be in a situation of an institution that will accept risk, come on in. We're going to have so many people in our system that we can afford to distribute the risk throughout them. And you personally, as a practicing physician, will not be on the hook for that. In addition to which, the tools that you need in order to manage patients for risk, electronic medical records, care management, all of those kinds of things, we provide, and we get the economies of scale for them. That's really what large medical systems are going to look like in the future. Now, it's not to say that there won't be people in private practice in a variety of different communities for a long period of time, but there is both a pull for those physicians and a push to those physicians. And you have to understand what are the dynamics working on both sides of that in order to know where you're going to go.
20 years ago, NYU Langone, which was not called NYU Langone, had very few doctors who were working for the hospital full-time.
That's right.
The number has changed dramatically.
Right. It has increased tenfold. We now have 1,800 physicians who are employed, but we have a vital, important to our system, voluntary staff. And that's true in Brooklyn with Lutheran, and it'll be true with other providers. As you know, we're in discussions with the Winthrop now. And I think, as Andy said, to do modern medicine, the infrastructure that's needed, whether it's an electronic medical record or whether it's care management or home visits, is very difficult for a private physician to do.
Two questions, okay? The feeder, I hate to say the feeder network. Mm-hmm. When you have these other hospitals, okay, and you have these centers of excellence that you're talking about, the feeder hospitals in Westchester or the feeder hospitals in certain parts of Long Island, sending them to North Shore or LIJ or to the Feinstein Institute or the Katz Pavilion, they're important. In the same manner, you know, you have Lutheran, okay, and, you know, maybe Winthrop one day, duplication of services or ability.
Well, you know, this has been a source of contention over the years, and if you take a look at the Northwell model and before it for North Shore Health System, North Shore LIJ Health System, now Northwell, that model is different than some of the other healthcare systems. When Northwell merges with, let's say, a community hospital, an average size 250, 350 bed community hospital, the thinking is not to reduce the services that are provided at that particular hospital. The idea is, of course, that if you can provide services at a hospital, a tertiary hospital within the Northwell system, you certainly would encourage the referral to a hospital, a tertiary hospital Northwell system. However, the idea, the plan, the system has never advocated for reducing services at any of the hospitals that have merged into the system. So if they're providing particular procedures or services or care, that will continue under the
But if you
Northwell
have
banner.
And Mike, and I agree with you, we want to provide as much care as possible in the local community. And again, the movement to ambulatory care allows that. We have a multi-specialty practice in Queens. We admit most of the patients for hospitalization there to New York Hospital Queens. We even have a hospitalist, NYU hospitalist at New York Hospital Queens. The patients who need to come to NYU come to do the things that we do better than anyone else. Skull-base surgery, pediatric cardiac surgery, oncology surgery. It's a very small percentage of what comes in. Most, and we feel very strongly about this, we want to take care of people in the community in which they live. We're going to do that at Lutheran, and we do that around the region. It's important. Again, it's an access and patient convenience issue, and we think we can do it well.
You're in the insurance business. Tell me about being an insurance company, taking care of a community.
The logic behind forming Care Connect and a vision of Michael Dowling, the president and CEO of Northwell Health, the logic or the thinking behind it is, as Michael said from the very beginning, the ability to control the premium dollar and put more of the use of that dollar towards the provision of care and wellness to the individual member who participates. Now, This has been a difficult path. I think you'll find that most of the insurance carriers that are on the exchange in New York State have lost money. One has gone out of business. Significant one has gone totally out of business. And so it's a new endeavor for the system. I agree that Michael's decision to move forward and commit resources to Care Connect is a good move. And I think some of the lessons we may have learned from Montefiore, for example, in terms of population health, in terms of what's called Care Solutions at Northwell, is where you have a division of Northwell working alongside the insurance company, following the care and the well-being of each member. Now, at this point, some 100,000 people are covered lives within the Care Connect insurance business, but they are followed very closely by Care Solutions in terms of making sure that they have their annual physicals, their checkups, their screenings, all important in terms of combining the two resources together. And of course, when the need arises to provide care, regardless of the degree of care that's needed, the provision of care is provided.
The issue, I think, gets back to what we had been discussing previously, and that is, where does the risk sit? So Dr. Safier at Montefiore for many, many years said, look, we are in the risk business, and we're going to be in the risk business going forward. Strategically, what that means is we want to be high on the premium stream. What we used to say is we'd go to the insurer and we'd say, okay, you're getting $100 for the premium, you're going to take $20 off the top, and then you're going to negotiate with us for the other $80, how much you're going to pay us for a physical exam, what you're going to pay us for a chest x-ray, how much you're going to pay us for this procedure or that procedure. Dr. Safier's view is, he said, no, we're going to go to the insurance company and we're going to say, look, guys, we'll take $95 out of that premium, but then anything that happens to the patient is on us. That practically makes us the insurer from the standpoint of managing the patient. What it doesn't do is it leaves for the insurance company themselves the idea of claims management, having to have certain kinds of reserves, a whole bunch of actuarial calculations that we don't need to get involved with. But in terms of the risk assumption, we at Montefiore are in the risk business and have been all along and will continue to be, because that's really where it is that you can manage the patient and where the financial implications of your decisions and the clinical implications of your decisions come together at the same nexus.
And I think you see a good spectrum here. NYU has no intention of being an insurance company, but we will take risk and progressive risk. We have 200,000 patients now in 8 commercial ACO arrangements, where we manage our own employees, 25,000, where we're at full risk for that. We're the payer, we're self-insured. And we're also in bundled payment, which we see as a good model for certain conditions in terms of getting the entire system to collaborate over a 90-day episode. So we want to take risks, but we won't be an insurance company. We will be a provider that manages clinical and financial risk over time.
Everyone has been heavily or becoming more active in mergers and affiliations. How do you, there was an involvement in New Jersey with you. It's the sister state. It's right over there. And then there's the Connecticut situation over there. How do you make a determination of who you might want as a merger partner, or who's the appropriate personality to mend in with your own institution? And you've been probably the most active over the last couple of years.
I think it all comes down to value added in terms of if a relationship with another organization results in value added benefits to Northwell and to the new partner, and it makes sense for both, and we can benefit from it together, then it makes sense regardless of the geography. And I believe healthcare has come to a point, and this is all about the transformation of healthcare. My first job in a hospital was in 1975, and the thinking was the longer you keep a patient in the hospital, more money you make.
The previous CEO of Montefiore said people would stay for the season.
Right.
That's no longer true. It's now our length of stay is 4.1 or 4.2 days.
Where
a lot
we
of
are
it
in
depends
most
on
of the
why.
hospitals
Right.
system as well. But reimbursement and the way we look at paying for the provision of care has changed so dramatically over the years. And retrospective payments at one point. The hospitals in New York and in New Jersey had no control over what they could charge. They watched their infrastructure fall completely apart because they weren't getting reimbursed at a pace that would allow them to build up new infrastructure.
Right.
So, you know, what we've seen in that transformation, I remember when DRGs came on the scene, New Jersey was the first statewide to introduce DRGs. And within a period of some 5 years, 20 hospitals in the state of New Jersey closed.
Right. That's such an important point because what it illustrates is how the reimbursement system drives the delivery system. They closed because the number of hospital days went down. Instead of a length of stay of 10 days, it was 5 days. So, and the same is true right now. The reimbursement system, including risk, will drive how the delivery of care
to my point.
occurs.
And that's why this new transformation in the way we get paid and the way we deal with our patients, those 20 hospitals closed because they couldn't manage DRGs. They could not manage the length of stay, to your point. And what we're seeing now is what you're seeing hospitals do in terms of diversification, in terms of partnerships, in terms of spreading their geographical footprint, is a reaction to the transformation of healthcare as we see it today.
Transformation of healthcare, concierge service. I hear a lot of doctors, especially in Florida or in certain parts of New York, they want to have a concierge service. Is that becoming active more at the NYU or at the Northwell system? Are you losing doctors to become part of this?
I haven't seen the impact that we thought we would originally see. There was an initial bounce from the whole concept of concierge care, but
Would you explain to my audience what a concierge service is?
Well, in terms of a physician who's involved in concierge service, is that they get a mostly monthly fee from someone who's interested in being, and access, that individual for that monthly fee has pretty much open access to the physician or a member of the physician's group 24 hours a day, 7 days a week. The bump, and again, I sound like I'm a dinosaur, but when you think back to a period of time where no one had to worry about their health care, when basically you paid a $100 deductible and 80% of the cost, and once you reach $1,000,
the good days of major medical.
Right. So major medical. So when you're accustomed to that, and most of the people who would benefit from concierge services are still of the mindset that why should I have to pay $3,000 a month, for example, to have this service from a provider when I should be getting this from my insurance?
It's a patient access, patient satisfaction. One would like to have a system that worked for everyone, and that's certainly what we're striving for.
In a similar manner, many of the hospitals, okay, I know Sinai had it, I think NYU may have it, you have a certain number of rooms which are like hotel facilities.
We don't have that.
You don't have that. But I know Sinai has it, and do you have it?
Atlantic Hill.
Atlantic Hill.
There's no VIPs, and everyone's a VIP. I mean, that is the standard. And we, in the new hospital, which will be all single rooms, 380 beds, the same will apply.
So, in conclusion, after doing 2 broadcasts on there, it's still a difficult maze to understand, and there's lots of things happening, but I'm happy that I've had the leaders of the preeminent systems who know where it's happening and who've been rated by U.S. News and World Report and other ratings companies as the best. And I'd like to thank Tony, Gary, and Andy, and I'll see you next week.